Hello and welcome. I'm Rob and this is my presentation on pulmonary embolism. If you have any further questions after the presentation, please feel free to ask them on the class discussion thread. But for now, get your favorite snacks and soda, settle in, and enjoy my presentation. This presentation will consist of a brief overview of pulmonary embolism, some steps and symptoms, the etiology, pre-hospital diagnosis and treatment, in-hospital treatments, and then of course the all-important summary. A pulmonary embolism, put simply, is a blockage of the pulmonary artery. The pulmonary embolism shown here is more specifically referred to as a saddle embolism, as it is straddling the split and is blocking or partially blocking two major arteries. The pulmonary embolism consists of a clump of material that becomes wedged in the artery in the lung. The material is most commonly blood clots from deep veins of your legs, and in many cases, multiple clots. The portions of the lung served by each blocked artery are robbed of the blood and may die. This is known as pulmonary infarction. This makes it more difficult for your lungs to provide oxygen to the rest of your body. Okay, here comes some stats at you. Pulmonary embolism is the third most common cardiovascular disease after heart attack and stroke. The CDC estimates a rate of 1 to 2 pulmonary embolisms per 1,000 people per year in the United States alone. The mortality rate of acute pulmonary embolism is approximately 7 to 11%. It is estimated to cost the United States healthcare system $30,000 in the first year after diagnosis of each case. How does it kill? Well, the first way is obstructive shock. The blockage in the pulmonary artery increases the pressure the right ventricle must pump against, causing the right ventricle to dilate and strain, which then displaces the septum into the left ventricle. This reduces preload to the left side of the heart and impairs contractility of the left ventricle, resulting in hypotension and shock from a reduced cardiac output. The second way it kills is respiratory failure. An obstructed pulmonary artery causes a ventilation-perfusion mismatch. The obstruction reduces the surface area available for gas exchange in the lungs. So when oxygen-rich air reaches the alveoli on inhalation, there is no blood available for gas exchange. Less of the inhaled oxygen is then diffused across the alveoli into the bloodstream, causing hypoxia, while less CO2 is released from the bloodstream into the alveoli for exhalation, leading to hypocapnia. There are several different severity classifications, the highest being the massive PE, which is the highest risk, defined as having no pulse, a heart rate less than 40 beats per minute, and signs of shock or continuous hypotension. Note, these patients may need immediate resuscitation. The second classification is submassive PE, or moderate risk, consists of a systolic blood pressure of at least 90 with some signs of cardiopulmonary stress, such as right ventricular dysfunction or myocardial necrosis, is defined by an elevation in troponin. And the third is a non-massive PE, or low risk, and it may not show any clinical or hemodynamic signs or right ventricular dysfunction based on echocardiogram or biomarkers. Some common signs and symptoms. Shortness of breath. This symptom typically appears suddenly and always gets worse with exertion. Chest pain. You may feel like you're having a heart attack. This pain is often sharp and felt when you breathe in deeply, often stopping you from being able to take a deep breath. It can also be felt when you cough, bend, or stoop. And the cough. The cough may produce bloody or blood-streaked sputum. Other signs and symptoms. Rapid or irregular heartbeat, lightheadedness or dizziness, excessive sweating, fever, leg pain or swelling or both, usually in the calf caused by DVT, clammy or discolored skin, known as cyanosis. But here's the thing. Over 90% of patients present with difficult or rapid breathing or chest pain that mimics ischemic angina. Patients may also be tachycardia. Others may present with coughing or syncope. Only 5 to 7% of patients will present with the classic symptoms of pulmonary embolism, reported as a triad of shortness of breath, chest pain, and coughing. We have established that the pulmonary embolism is a blockage of one of the pulmonary arteries in your lungs. But what causes this blockage? DVT, DVT, DVT. That's right, folks. Deep vein thrombosis, otherwise known as DVT, is our culprit. The DVT occurs when a blood clot, otherwise known as a thrombosis, forms in one or more of the deep veins in your body, usually in your legs. You can tell in our graph here on the left, the normal vein, blood moving toward the heart at a normal pace, rate, all that good stuff. In the middle section, the thrombosis stage, damaged, open, and warped valves occur, blood flowing in both directions, and blood accumulating in the vein. As this increases, you move to the embolus stage, when blood moving slowly, a clot or thrombus can form. Part of this clot can break off and travel in the bloodstream, known as an embolus. That is what flows through the heart into the pulmonary arteries. The DVT symptoms are as follows: swelling in the affected leg. Rarely there is swelling in both legs. A pain in your leg. The pain often starts in your calf and can feel like cramping or soreness. Red or discolored skin on the leg. A feeling of warmth in the affected leg. Deep vein thrombosis can occur without noticeable symptoms also. Other causes of the pulmonary embolism include surgery, particularly abdominal or orthopedic surgery such as hip or knee, trauma or bone fracture, a long period of bed rest or sitting for a long time, like on a car ride or a flight, cancer and some cancer treatments like chemotherapy, cardiovascular disease such as atrial fibrillation, heart failure, heart attack, or stroke, pregnancy and the first 6 weeks after giving birth, birth control pills, or hormones that are taken for symptoms of menopause. Additional causes are family history of blood clots, inherited blood disorders that make the blood thick, such as thrombophilia, inflammatory bowel disease, autoimmune diseases such as lupus, smoking, obesity, or placement of vein catheters, pacemakers, or implantable defibrillators. All right, we've learned a lot about pulmonary embolism. Let's take all this knowledge to the streets. Pre-hospital diagnosis. The complexity of the pulmonary embolism presentation frequently results in the diagnosis of exclusion, but if suspected, and in most cases it is recommended to begin parenteral anticoagulation while the workup is in progress. Patient history. Patients with pulmonary embolism often complain of difficulty breathing, which may come on suddenly from a large pulmonary embolism, or come on gradually, intermittently, or with exertion from a small emboli. They may also have a non-productive cough, hemoptysis, or low-grade fever. Pleuritic chest pain. Chest pain described as sharp or stabbing, and which increases with cough, movement, or inspiration, is another common symptom of pulmonary embolism. Syncope and altered mental status, which suggest a compromised cardiac output, are additional signs of a pulmonary embolism. DVT. Inquire about symptoms and risk factors for a DVT, which include extreme immobilization, recent surgery, recent travel over 4 hours, pregnancy, oral contraceptive use, and smoking. Patients may complain of localized leg pain with a DVT or abdominal or flank pain from a thromboembolism that formed in the pelvis, abdomen, or kidneys. The physical exam. Observe patients for signs of respiratory distress. Patients with pulmonary embolism are usually tachypneic and tachycardic. Skin may be pale, diaphoretic, and cyanotic. Lung sounds may be clear or have crackles or wheezes. Look for signs of right-sided heart failure such as jugular distension and peripheral edema. Inspect and palpate the legs for localized pain, swelling, or warmth or redness from a DVT. Respiratory and cardiac monitoring. Pulse oximetry and waveform capnography provide feedback on both respiration and perfusion status in the pulmonary embolism, both at baseline and after treatment. Hypoxia from a decreased blood oxygen concentration causes a low SpO2 reading. while decreased perfusion to the lungs and reflex hyperventilation to compensate decreases the end-tidal CO2 reading. And because pulmonary embolism obstructs pulmonary blood vessels, not the airways, capnography waveform should have a normal crisp shape. Thus, low SpO2 and low end-tidal CO2 with a normal capnography waveform and clear lungs strongly suggest a pulmonary embolism. Pre-hospital treatment. Treatment goals for pulmonary embolism are to improve oxygenation and cardiac output. Administer supplemental oxygen via the nasal cannula or non-rebreather mask to maintain SpO2 above 94%. But be aware that reduced blood flow to the lungs may prevent improvement of hypoxia from oxygen administration. For patients with adequate blood pressure who remain hypoxic, CPAP may help by increasing oxygenation delivery to the lower airways that are perfused. While necessary for patients in respiratory failure, positive pressure ventilation with a BVM also compromises cardiac output. Deliver only enough end-tidal volume needed to make the chest rise, and use waveform capnography to guide ventilation rate. You should also start a large bore IV on patients with a suspected pulmonary embolism, but limit IV fluid administration as this adds to the stress of the failing right ventricle. Use a vasopressor to treat sustained hypotension, preferably norepinephrine, which works by increasing afterload of the left ventricle without adding stress to the right side of the heart. And after you've done all that, your patient needs a large dose of diesel intervention. Now you've gotten to the hospital. What do? Well, hospital diagnosis includes electrocardiogram, a chest x-ray, an echocardiogram, and a CT pulmonary angiography, known as a CTA. A workup may include D-dimers, a fibrin degradation product from the blood clot, biomarkers of myocardial injury. When there is damage to the heart muscle, troponin is released to the blood gases, clotting tests, such as an INR test that measures the time for your blood to clot, and ventilation perfusion scans. In-hospital treatments. The pharmacologic options include parenteral anticoagulation. They may be used alone in patients who are not candidates for TPA or are initiated at the end of the TPA infusion. These medications prevent further clot formation and work in the coagulation cascade to enhance the body's ability to dissolve existing clots. Another pharmacologic option is thrombolytics. Patients with massive PE who are not at high risk of bleeding are candidates for systemic thrombolytic therapy with alteplase, also known as tissue plasmogen activator, or TPA. Non-pharmacologic treatment is considered when there's a high risk of bleeding and thrombolytic therapy is contraindicated. These options include catheter-directed therapies, embolectomy, and suctioning. Catheter-directed therapies include ultrasound, pressurized saline injection, catheter-led mechanical disruption of the thrombi. Delivery of the catheter-directed therapy may involve thrombolytics, but used in smaller doses than are used in systemic thrombolytic therapy, therefore lowering the risk of bleeding. The surgical option includes a pulmonary embolectomy. This should be considered if a patient has hemodynamic instability and the thrombolytics therapy is contraindicated. Surgical suctioning is also an option. Suctioning may remove a thrombus, a thrombolectomy, or thrombi fragments. The post-hospital treatment includes oral anticoagulants such as warfarin and aspirin. In summary, the pulmonary embolism is a result of a clot in the pulmonary artery or one of its branches. If untreated, the pulmonary embolism can result in death. Goals of the initial treatment include clot resolution. Long-term and extended treatment aim to decrease the risk of this reoccurrence. Additional goals include decreased risk of consequences of pulmonary embolism, such as death, pulmonary hypertension, and impaired functional outcomes. Treatment selection is patient-specific and depends on symptoms, bleeding risk, and comorbidities. Treatment options include surgery, non-pharmacologic therapies, and pharmacologic therapy, which includes thrombolytics and anticoagulants.